Before we dive in, I'd like to go over a few quick housekeeping items to help everything run smoothly today. Please note that today's Lunch and Learn will be recorded. You probably just heard her hit the record button. If you're joining on Zoom, please make sure that your microphone is muted throughout the presentation to minimize background noise. You're welcome to turn your camera on if you would like to. It's always great to see faces. If you have any questions during Dr. Sanchez's presentation virtually, please type them into the chat. Our AHA team is monitoring the chat and will share those questions aloud during the Q&A portion. For those here in person, you will have the opportunity to ask your questions using our portable microphone during the Q&A portion. Please speak clearly and toward the microphone so that our remote colleagues can hear you. Most importantly, everyone, both in-person and virtual attendees, must complete this pre and post-event surveys to receive credit or feedback certificates. If you completed the survey on the welcome screen, thank you. It is the same one on the screen right now, and you do not have to complete it a second time. But if you have not yet filled out the pre-survey, I will give you a minute to scan the QR code on the screen to access it now. We'd also like to share the following disclosure information with everyone. I'll give you guys a second to read through it. And now, Executive Director of AHA Greater Louisiana will introduce our speaker.
Thank you, Nicole. I'm Karen Spears, Executive Director for the great state of Louisiana, and I'm excited to be here and honored that y'all took time out of your day to come learn more about your health, and hopefully you're going to take away some great nuggets. And I am also excited that I can introduce today's presenter, Dr. Eduardo Sanchez. I love this guy. Dr. Sanchez serves as Chief Medical Officer for Prevention for the American Heart Association. He was principal investigator from 2020 to 2024 of the National Hypertension Control Initiative, an agreement with the U.S. Department of Health and Human Services Office of Minority Health and the Health Resources and Services Administration. He is the AHA lead for Target Blood Pressure, a joint blood pressure control initiative with the American Medical Association. Before joining our organization, he served as Vice President and Chief Medical Officer for Blue Cross and Blue Shield of Texas. Dr. Sanchez was Commissioner of the Texas Department of State Health Services from 2004 to 2006. He serves and has served on numerous local, state, and national health-related boards of directors and advisory committees. The title of today's presentation is High Blood Pressure, What Women Need to Know. At the end of the session, you will be able to explain that hypertension is highly prevalent, a major factor contributing to cardiovascular disease mortality and stroke mortality, and the most important modifiable risk factor for cardiovascular disease. You'll be able to explain the relationship between hypertension control and its effect on dementia. And you will also be able to explain the importance of addressing high blood pressure in pregnancy. And I will go ahead and hand it over to our esteemed speaker, Dr. Eduardo Sanchez.
Y'all can see me. Thank you for having me. I'm so disappointed that I cannot be in Baton Rouge. Louisiana is one of my favorite states to go visit, has been for a little while. Although my daughter is now a graduate of Tulane, I got to spend a little bit of time in New Orleans. Thank you for what you do every single day to make a difference in people's lives. And I would just share with you that at the time that I was Commissioner of Health 20 years ago, around this hurricane season, 350,000 of your fellow Louisianans came to visit us in Texas. Some stayed, many were able to go back to Texas, all the result of Hurricane Katrina. It's the reminder of what you do, what we do, which is to serve and try to serve people in regards to their health. So thank you so much for having me. I've got a PowerPoint presentation that I'm going to try to walk us through as part of this Lunch and Learn. So while I get things set up here, we're going to share. And I think you should be able to see the PowerPoint in front of you. I will make it so that all you see is the PowerPoint. I hope that works. Today, I'd like to talk about high blood pressure, what women need to know. I will tell you that I'm going to talk about high blood pressure in general for the entire population because it affects women and men, and then talk about that part of hypertension that might be exclusive, well, might be nothing, is exclusive to women, and that's hypertension associated with pregnancy. So here we go. High blood pressure is very prevalent and is the most modifiable risk factor for the development of cardiovascular disease, and that includes coronary artery disease, heart failure, atrial fibrillation, but also includes, if you didn't want to categorize it as such, stroke, also includes dementia, chronic kidney disease, and all-cause mortality. High blood pressure is a significant factor contributing to cardiovascular kidney metabolic disease, which was defined by the American Heart Association in 2023, and for which a clinical guideline will be coming out in early 2026. I want to emphasize that for people who are not pregnant, the overarching blood pressure treatment goal is to get to less than 130/80 for all adults, with some consideration for those who are requiring institutional care, think nursing home, have limited predicted lifespan, someone who is truly end stage of any condition, and then those who are pregnant. Prevalence of hypertension is high, as defined by persons who have blood pressure above 130 millimeters over 80 millimeters of mercury or above. 45% of adults in the United States have hypertension or are taking blood pressure medications. Approximately 87 million, the bottom bullet, have type 2 hypertension, and type 2 hypertension is that type of hypertension that generally being the operative word, requires medications to bring that blood pressure below 130/80. Prevalence of hypertension is high, and it's going to get higher from about 50% in 2020. So I do want to note that the 45% was from 2016. It's gone up to over 50%, and the projection is that it will go up to 61% or so in the year 2050. And that's driven by two things primarily. One is the aging of the population. That's a non-modifiable risk factor. The other is the increasing prevalence of obesity and overweight in the United States. The American Heart Association is not the only organization talking about the importance of controlling high blood pressure. The U.S. Surgeon General in 2020 put out a call to action, and in just this year, a few weeks ago, the World Health Organization released a global report on hypertension. And the bottom line message is there is opportunity to get blood pressure under control in most people and to reverse trends related to heart attacks, strokes, dementia, chronic kidney disease. In the United States, leading causes of death are listed here. And in red, I've listed ones where there is a direct correlation between blood pressure control and the disease. And these numbers would improve if we could get blood pressure under control. For heart disease and stroke, I would say they could improve when you include myocardial infarction. They would improve fairly quickly. Within months, one could begin to see changes in patterns of myocardial infarction and stroke, because getting blood pressure controlled reduces the likelihood that a heart attack or a stroke is going to happen in the moment. Alzheimer's disease and kidney disease, longer-term positive effects. I'm going to talk a little bit about live births, deaths, and maternal mortality in the United States, and then a little bit by race and ethnicity. This is from 2022. The numbers overall are about 17 deaths per 100,000 per year. And you can see that when you break it down by race, ethnicity, what should jump out to you, which I'm going to show you, well, first of all, is that if you are a person who's pregnant and 40 and over, maternal mortality jumps up in all categories of race, ethnicity. And then for Black women, you can see that the maternal mortality is markedly higher than it is for non-Hispanic white women and Hispanic women, and then compared to the total. When one looks at and includes all races, including persons who are Asian, again, you can see that the mortality rate for non-Hispanic Black women on this chart just demonstrates more than 2 times higher, and in some cases almost 5 times higher than any of the other groups that are characterized here. So it seems to me that is the thing we ought to be asking why that is and what can we do to change that. The U.S. has worse maternal health and health care than other industrialized nations. Again, the overall rate, this is a different set of years, but here you've got overall 24 deaths per 100,000, and other statistics about severe maternal morbidity rate, which is fairly high in the United States and increased between 2016 and 2019. I would say to you that sometimes when we look at not only causes of death, but when we look at things like life expectancy, we may not be capturing the full negative contribution, the full adverse effect of maternal and infant death. And so one way to capture the full impact of maternal and infant death is to look at years of potential life lost. That infant that dies early or dies in pregnancy or early in life is an infant whose life will never be realized, won't live the 70 to 80 and potentially to 90 years that a child who's born and stays alive would live. And the same for a mother who dies at 26 or 36 is a person who's not going to realize that full life. And so this is a way to capture what might not happen as often as heart attacks and stroke, but for which the impact as measured by years of potential life lost is equally important and equally impactful. I'm going to talk a little bit about Louisiana, y'all's data. And what I want you to see is that the order of the list of diseases is not unlike what it is in the United States. Heart disease is the leading cause of death. Stroke is number 4. You could see Alzheimer's there at number 6 and kidney disease at number 8. I do want you to look in the little box. Life expectancy, despite everything I said, it is a way that we measure things. Life expectancy in Louisiana almost, well, actually more than 4 years lower than it is in the United States overall. Cause for concern. According to America's Health Rankings, the health of Louisianans is there's a lot of room for improvement. Overall, Louisiana's health ranking, at least the way this is measured, is at number 50 out of 51, because it's the 50 states plus the District of Columbia. And in all of these categories, except for dedicated healthcare provider, there is a lot of room for improvement. I would also say that with dedicated healthcare provider, as high as it is compared to other states, the opportunity to change some of this is really quite substantial. When we consider the 2024 state scorecard, this was done by the Commonwealth Fund, and look at Louisiana, what you can see is that when one looks at women's health, except for the category of abortion clinics per 100,000, I would say Louisiana fares fairly well. And if you were to see how it ranks or how it rates compared to Texas, it's doing fairly well in terms of the systems of care and the way it offers access to women. So there's opportunity for improvement. I would say that the percent of women with a recent live birth without health care insurance, that number should be a low number, not a high number. When one compares to the states that have the best scores and the states that have the lowest scores, I'm just showing you this. You might be able to see and think about comparison states. You can see that Louisiana is close to 3, if not 4 of them contiguously: Georgia, Arkansas, Texas, Oklahoma. I'm going to go back to leading risk factors for cardiovascular disease. I said earlier that hypertension is the most modifiable risk factor. And at least according to this analysis, hypertension, when one looks at population attributable fraction, how much does this disease contribute to cardiovascular or any of these conditions? What you can see is that hypertension is a major contributor and is the leading contributor by far. I'll just point out to you that cholesterol is on there. It's number 2 on the list. Tobacco use is on there. It's number 4 on the list. Poor diet is on there. It's number 5 on the list. Diabetes is on here. It's number 8 on the list. Low physical activity is number 10 on the list. And I'm going to point out, because I think I'm coming back to that in a moment, that low education is number 6 on the list. The most important thing on this slide, hypertension, number 1 by far. It's more than any 3 of them combined, more or less. Blood pressure control varies by a number of sociodemographic factors. Women have slightly better blood pressure control, whether you're looking at the overall population, and this comes from national data. So it compares, it's looking at a representative sample of all people in the United States, and all people in the United States with hypertension have a control rate of 51.1%. I do want you to look at the column next to there that shows that the control rate for persons with hypertension who are on medication is 68.3% in this study. And the take home to you is, and I don't think it would be a surprise, if you have hypertension and you are on medication, that's better than having hypertension and not being on medication in general. I do want you to see that in red, women's blood pressure control is slightly better than that of men. And I think important to point out also is that when we look by race, ethnicity, they're fairly equal. However, I do want you to note that non-Hispanic, Black, and Hispanic persons have the lower of those blood pressure control rates in the category that's overall, and that one looks at the category, well, actually, that's also true in the other category of control rate with hypertension and on medication. But I do want to highlight that in that column, the group with the lowest blood pressure control, non-Hispanic Black persons. On medication, not controlled, those are opportunities to make a difference from a clinical perspective. Now I want to focus on this slide for a minute, because these are more socioeconomic factors. They line up with what I said, well, they line up with might be also an opportunity to think about what can be done or what should we be thinking about when we take care of people who have high blood pressure. And I want you to see that it appears on this slide that education, degree of the level of education correlates with the degree of blood pressure control. So low educational attainment equals lower blood pressure control rate. When you go to the control rate with medication, again, always higher. Income also correlates, low income correlates with low blood pressure control. And as you go up in household income level, you see blood pressure control going up. So in either column, in that 4 through 7 rows, you can see income levels. What kind of insurance you have matters. And I hope it's no surprise that persons on Medicare seem to have the highest level of control and in both categories. And those with, interestingly, those with private health insurance have slightly lower blood pressure control rates than those who are uninsured. And I think the most important thing to highlight here is that if a person has no routine place for care, irrespective of the column, their blood pressure control levels are very low. And even those with no routine place for care and on medication, blood pressure control is just a little over 50%. So the point here is there are sociodemographic factors, sex, race, education, income, and kind of insurance, and whether you have care or not, that correlate with blood pressure control. Those are things that maybe we can work with, address, think about when we're taking care of patients. I'm going to shift gears because in August of 2025, a new guideline was released for the American Heart Association. And that guideline covers some new territory that I want to talk about today. This isn't new, but I do want to say the definition and classification is well described in the document. What I want you to see is that, as I said earlier, hypertension is 130/80 and above. And if you are at 120 to 129, we call that elevated. And normal, maybe we could call that healthy, is less than 120 millimeters of mercury over 80 millimeters of mercury. Do want to focus on this slide for a moment. This is a slide that talks about lifestyle and psychosocial approaches for blood pressure management. All persons in whom you are trying to prevent hypertension, so that's everybody, and in persons who already have hypertension, these lifestyle and psychosocial approaches have value in at least knowing. So on weight, trying to get people's weight at a healthier place, and weight loss of more than 5% can result in a reduction in blood pressure. Eating healthy, you've all heard that before, and the new guideline includes language specifically about potassium-based salt substitutes. I want to show you that the colors that are green are ones where the evidence base is very, very strong with very, very rigorous studies, randomized controlled trial being what informs those. The other two, the different shades of orange, of yellow and orange, are good evidence, but not as strong as class 1. I do want to emphasize that one of the class 1 recommendations that's new is that in persons with or without hypertension, abstaining from alcohol is a recommended approach, is a recommended strategy. For those of us who can't or don't want to abstain, moderate use of alcohol is part of that recommendation. But this is new, particularly in persons with hypertension, to suggest the evidence says not drinking, quitting drinking would be the best thing to do for your blood pressure control. And then I also want you to see that stress reduction with examples of meditation and yoga are included in the guideline. Home blood home blood pressure monitoring, that is measuring blood pressure outside of the clinical care setting, either at home or with ambulatory blood pressure monitors. Those are the devices that you might wear for 24 hours while your doctor is monitoring you. Those are both ambulatory and home blood pressure monitoring are recommended to confirm the diagnosis of hypertension. That would be an instance where Miss Jane Doe is at a health fair, gets screened, her blood pressure is high. That person ought to be connected to clinical care. And in the clinical care setting, the first step is to confirm that the blood pressure is high. Of course, blood pressure is going to be taken in the office, but generally what will happen is that the patient is either put on ambulatory blood pressure monitoring, might be a better way of saying it, or home blood pressure monitoring, and using a protocol for home blood pressure monitoring and the algorithms to analyze ambulatory blood pressure monitoring, the determination will be made if a person's got high blood pressure or not, hypertension or not. The other role for home blood pressure monitoring is that instance where Miss Jane Doe now has been put on a medication. She comes in and sees the doc the first time, or the clinical care team. They see that the blood pressure is not at 130/80, below 130/80, and they make a plan to add a new medication. I'll talk about that in a moment. And they send her out with a home blood pressure monitor, or they say, use your home blood pressure monitor according to the protocol, 2 measurements in the morning, 2 at night for 3 to 7 days. And I will pretend that Ms. Doe has a machine that will feed all of that information to the electronic health record. Not always the case. That's the ideal. And it calculates an average, and a decision can be made. And let's pretend that in this instance, Jane Doe's blood pressure is good. Then the message by phone can be, you're good, Ms. Doe, and we will see you in 3 months. Or if her medication continues to be elevated, the message might be, go to your pharmacy. There's going to be a new medication for you to take. I do want you to see that at the bottom of this, the use of cuffless blood pressure devices is not recommended for the diagnosis or management of high blood pressure at this time. Using risk-based thresholds for initiation of blood pressure treatment basically says if a person's blood pressure is at 140/90 or above, you should start them on medications, and also start them on lifestyle change. It also says, number 2, that if they have existing clinical cardiovascular disease or diabetes or chronic kidney disease or at increased risk of cardiovascular disease using the Prevent Cardiovascular Disease Risk Estimator, they should also be started on antihypertensive medications. What medications? The guideline says thiazide type diuretics, long-acting calcium channel blockers, and then those that are in the ACE-ARB families, angiotensin converting enzymes or angiotensin receptor blockers. However, the guideline also says in persons with stage 2 hypertension, ideally, people should be started on 2 of the first-line agents, 2 out of this category, ideally in a single pill combination. Single pill combination means the 2 are combined in 1 pill. Hopefully, you only have to take it 1 a day. That helps improve adherence to your medication therapy. Other things, in addition to single pill combinations that improve adherence, include education and coaching, medication synchronization, reminders, home blood pressure monitoring, really just to kind of be that prompt that, oh, I need to be taking my pills, I need to be eating my DASH diet, et cetera, and so on. I need to manage my anxiety and depression. Once daily dosing, class 1 recommendation. If you can get somebody on 1 pill once a day, that is ideal. Now I'm going to shift gears. Also in the guideline, hypertension and pregnancy. A few things that I'm going to share. Pre-pregnancy cardiovascular health, that is being healthy when one becomes pregnant may reduce adverse pregnancy outcomes. I think that's a thing you'd say, well, of course, the science is pretty strong in that regard. The U.S. Preventive Services Task Force recommends screening for hypertensive disorders in pregnant persons with blood pressure measurements throughout pregnancy. The U.S. Preventive Services Task Force also recommends the use of low-dose aspirin as preventive medication after 12 weeks of gestation in persons at high risk for preeclampsia. Now, from the guideline, and what you're going to see is that this lines up with what I just said. Individuals with hypertension who are planning a pregnancy or become pregnant, that's a woman who is already pregnant. Already has hypertension. What are the medications that are indicated? It's a different list, and they should not be treated with the angiotensin converting enzymes or the angiotensin receptor blockers. And the list over here includes a calcium channel blocker. They should be counseled about the benefits of low-dose aspirin to reduce the risk of preeclampsia and its sequelae. And again, those are in green, class 1 recommendations. And in pregnant individuals, persons with blood pressure 160 millimeters of mercury over 110 millimeters of mercury confirmed on repeat measurement within 15 minutes, one should try to lower their blood pressure to below 160 and 110 within 30 to 60 minutes to prevent adverse events. And then with chronic hypertension, the goal should be in persons who are pregnant to maintain their blood pressure below 140 over 90, as opposed to 130 over 80 for all other non-pregnant adults. Also covered in the guideline are the diagnostic criteria for preeclampsia, and I'm not going to go through everything that's underneath. Elevated blood pressure and proteinuria, as you know, that's protein in the urine, or other criteria that are listed here. I do want to mention, once a baby is born, women are prone at a level that's been defined to suffer postpartum depression, approximately 7 to 15% of adult mothers yearly. And the U.S. Preventive Services Task Force recommends that clinicians provide or refer pregnant and postpartum persons who are at increased risk of perinatal depression to counseling interventions. And it recommends, and persons who have just had a baby should have expanded coverage, not only to take care of their overall health, but also to assure that postpartum depression can be addressed. Talk a little bit about Life's Essential 8, and that's why I have the 8 on my lapel. I will say to you that Life's Essential 8 is a life course set of practices, and they occur, you can see there's 2 cycles here. One of the individual who is born and goes through early childhood, adolescence, but then you see the interaction between the pregnant woman, and a baby. Life's Essential 8 has relevance in all stages of life, There are some mitigating considerations: stress and resilience, social determinants, and structural policies. Back to the guideline for a moment. And these, I think, are germane. These are germane for blood pressure control of all adults. And I would also say for blood pressure control in women and in pregnant persons. Team-based care approach is recommended, of course. It is a team, and each person has a set of skills, competencies that can be brought to bear to achieve the best outcome. Evidence-based care planning should include home blood pressure monitoring, but should also assess and address adverse social determinants, social drivers, non-medical drivers of health. And that is attention to the other factors that I talked about earlier that line up with poor blood pressure control. An integrated treatment model that includes accurate blood pressure measurement, prompt treatment, meaning when someone's blood pressure is not where it needs to be, Jane Doe, somebody that needs to be acted upon quickly and assessed within a month. Patient engagement also critically important. I'm going to focus here on health information technology can be our friend if we figure out how to use that tool as best we can. And electronic health records and patient registries can be very, very effective to know how we're doing in taking care of our patients, how we're doing in taking care of a group of patients, and ideally connected, as in this section on this section, connected to home blood pressure monitors that can be incorporated into the clinical decision making. Telehealth doesn't have quite a strong recommendation. I would say we still don't have the robust evidence, but directionally, telehealth can be very, very useful. Telehealth can be very, very useful in providing care for folks who maybe can't get in the car because they don't have one, or because if they do have one, it's very, very far away from clinical care. Telehealth can serve as a proxy for the care that maybe was taken care of within the four walls of a particular clinic. And I want to emphasize this the bottom column, the bottom row one more time. Adults with uncontrolled hypertension placed on new or intensified medical therapy should have follow-up evaluations for medication adherence and response to treatment at monthly intervals until control is achieved. RTC in 3 months, if someone's blood pressure is elevated, is the wrong RTC. It should be RTC or evaluate in 1 month. Was talking about accurate measurement of blood pressure. Doing it right and having the right equipment is critically important. Critically important. The American Heart Association has been working with others on something called the MAP framework. The MAP framework is measuring accurately, acting rapidly, partnering with patients. I've actually talked about all of this, the right equipment and the right technique, acting rapidly, intensify care, make sure people's blood pressure is under control in 30-day intervals until you get it under control. And partnering with patients includes lifestyle counseling as well as home blood pressure monitoring. So I think that was meant to tell me that I'm getting close to the end. Again, cardiovascular health and hypertension control, at least what one can do, are life course realities, all the way from, when you're a child to reaching older age. The slides I used came from Dr. Elliot Antman and a group of guideline ambassadors, they're called. They are mostly physicians who are fellows in cardiology, and then Drew Mills, who works with me. So with that, I'm going to stop and let y'all ask me questions. I'm kind of stunned. So either you didn't hear me or you're really shy. Well, now I know you heard me.
Hi, Dr. Sanchez.
Hey.
Thank you so much. Yes, we are going to open up to questions now. I believe that our team has the opportunity for anyone virtually to ask you in the chat. We also have the opportunity for anyone in person to ask questions. Does anyone have a question?
I'm looking in the chat, and what I get is we hear you. There is oh, what a great question. I was anticipating the first and a comment about the presentation. Is there any evidence for GLP-1 medications being helpful for lowering blood pressure? Any contraindications? So I'll start with this last question. The only contraindications would be any contraindications for the GLP-1 use in the patient themselves. There seems to be an associated modest is the operative word, blood pressure reduction in persons who are on GLP-1 medications. So what I would say to you is that you probably wouldn't choose to start somebody on GLP-1 for hypertension. You probably would start with at least one of the class 1 drugs, but you would medications, but you would also try to measure for what's going on if and when GLP-1 is added, because it will lower blood pressure a little bit more. So it has a positive additive effect to all the other things that GLP-1 medications do. Great question. It's modest at this point, the classes that have been studied, the GLP-1 medications that have been studied.
Oh, we have a question in the room. Can you still hear me, Dr. Sanchez? I'm walking with the
I can hear
microphone.
you. I heard somebody talking, but I couldn't hear what they said.
Okay, my question is, I think I remember you saying that when a patient goes to the doctor and is diagnosed with hypertension, to take the home monitor their blood pressure for 5 to 7 days after starting their medication. Do medications for hypertension have results that quickly?
So I'll walk through there. So I was not as crystal clear as I could have been. So one of the things I said is if somebody's gets screened in a event and their blood pressure's high, that person should walk away being told their blood pressure's high, but also told that you should go to your doctor so that they could set up and make a confirmatory diagnosis if indeed you have high blood pressure. So example, if you're doing hypertension screening at a sports event and your kid's team just scored a touchdown and you just got your blood pressure taken, or a basketball, or a volleyball spike, then your blood pressure might be a little elevated. So you go to the doctor's office and it gets done, and so one measurement gets done and it's normal. I still think that the team is obligated to make sure that one of those is right. It could be that it was elevated. It could be that it's normal. And the better part of valor is to have somebody go home and check their blood pressure. So that's the instance where you don't put them on medication. If you put them on medication, then I think, and I wasn't clear, you wait 5 to 7 days before they do that protocol. So within 5 to 7 days, the medication should be having its effect, and you would have somebody do the 2 in the morning, 2 at night for 3 to 7 days after they've been on the medication for 5 to 7 days a week. Does that help? So I'm going to keep going. For someone with early stage hypertension, any advice on how to ensure one is exercising safely or any warning signs? I'm somebody who believes that in general, unless somebody has a very clear indication that they might not ought to be exercising, a couple of things. Let me back off. But everything in moderation and always starts slow and build up. So in no instance are we going to say to people, I don't believe, well, why don't you do 75 minutes of vigorous physical activity once a week when you've not been doing anything for a while? So I'd say the comfortable thing to do in somebody who's got early stage hypertension is to maybe start with moderate activity during the week. That would be walking at a pace of about 3 to 4 miles an hour, which means you walk a mile in 15 to 20 minutes. That's a pretty safe speed. And if for any reason, at any point, someone is feeling anything, shortness of breath, tightness in their chest, pain in their legs, they should have a conversation with their healthcare provider about these are things that are happening even when I do moderate level physical activity. And if they're just starting anew, again, I think the advice should be, why don't you try 5 to 10 minutes of this most days of the week and work your way up to where you are. I think the other is age matters. So if you're talking to somebody who's in their 20s or 30s, and people in their 20s and 30s have hypertension, then that's a different recommendation, I think. And let's just assume they have a body habitus that at worst is in the overweight category. I think you can be a little bit more aggressive. If somebody's in their 60s and 70s and they haven't done anything in a while, I do believe the better part of valor is to start slow. I also think that in both instances, doing things with people is a good idea, who can also be aware of what's going on and help monitor how one feels, how it's going. If you can walk and talk, you're in pretty good. You're in pretty good shape to feel safe. Hope that helped. Questions from Baton Rouge?
Hi, I have a question.
Yes.
Are there any symptoms of hypertension that we should be looking out for, at home, and specific, and symptoms that may be specific to women?
In general, we say that hypertension is kind of the silent killer, and the silent it's the silent influencer of bad health. So the things that it's doing in your blood vessels, there's no symptoms, not early on, and by the time you have symptoms associated with hypertension, you're having an event, you're having a stroke, you're having a heart attack in general. So I would say the really, really important thing to say to people is the only way to know that your blood pressure is doing damage is to know what the level of blood pressure is. And I do want to emphasize one of the presentations that was done at the hypertension meeting. Here's one really important point. I talked about 130/80, but in the guideline, it goes on to say that if you can get your patient's blood pressure below 120/80, that's even better. And the evidence is very, very clear that damage to blood vessels, to your brain, to your kidneys is happening. Once you get at 120, you can see a stepwise increase in damage and in mortality across many studies, across many ages, and across many countries. I do want to say one of the things I said was the learning objective is that one of the key pieces of information that was included in the guideline is that a very, very large study conducted in China looking at blood pressure control and cognitive decline showed a very, very clear relationship and a 15% reduction in the risk of having cognitive decline in persons whose blood pressure was better controlled. And you may say 15% is not a lot, but let's go back and look at the number of people that die every year of Alzheimer's, which is a tip of the iceberg of the number of people in this country with Alzheimer's, which is a tip of the iceberg of the number of people who are at risk of Alzheimer's. And 15% of that number, which is tens of millions of people, is a huge number. So I put that out there. So the important thing is that hypertension doesn't have symptoms, and the idea that it gives you headaches, that might be true for some people. It is definitely not the case for the vast majority of people. No symptoms, you don't feel anything. The only thing you can look at to know whether something bad is happening in the moment in your home is to check your blood pressure.
I have a couple more questions in the room, Dr. Sanchez.
So for a normal, healthy adult, how often should you check your blood pressure?
It's a great question. I feel like for a normal, healthy adult, once a year is probably okay, unless as a normal, healthy adult, things suddenly change. Whether that's, example, you lose your job, that's a major, major stressor. That's the sort of thing where you would think, oh, maybe. If your weight goes up suddenly, that would be, and suddenly meaning over the course of a few months, you're putting on a fair amount of weight. But in general, if you are a healthy adult whose blood pressure was normal and there's no marked dramatic change in what's going on in your life, the other kinds of thing would be a spouse or a parent suffering a health issue, becoming a caregiver. That could be very stressful and might be associated with a increase in blood pressure. So I'd say once a year, and then unless something changes. Becoming pregnant is one of those things that changes. And when you are in prenatal care, blood pressure measurement should be done. I'd say the other thing is anytime you're in a clinical care setting, somebody ought to be taking your blood pressure.
Once you start taking blood pressure medicine, can you get off of it or you have to be on it?
It's a great question. And the answer is yes, you might be able to come off of medications. And I had patients who were started on medication and lifestyle, and they were able to come off their medications because they maybe lost weight, maybe they changed their dietary habits fairly dramatically, maybe they were doing a lot more physical activity. But yes, the answer is yes. But I do think it's really, really important to stress that the one thing that lifestyle doesn't do right away is change the likelihood of a heart attack or stroke or the onset or the exacerbation of heart failure. Whereas getting your blood pressure under control in that 5 to 7 day window takes you from being at high risk of having a stroke or a heart attack to being somebody whose risk has been reduced dramatically. If I know you know this, high blood pressure is the #1 cause of strokes. So again, getting blood pressure down quickly can only happen with medications. And then over the course of many weeks and months, as blood pressure comes under control because lifestyle change happens, one can sometimes come off of medications or lower the dose of medications. So that's a great question. I think it's really important to remind people that that is a possibility. The lifestyle changes that were in that slide I showed, I don't want to go back to the slides, have a millimeter of mercury potential drop. And so when you add all of those up, and they're not additive, so you're not going to drop your blood pressure to 0 if you did enough stuff, but you're going to be able to bring your blood pressure down below what you might just on the medication. And again, you might even be able to bring it down enough if you do enough of these changes: weight change, physical activity, diet change, salt substitution, to come off of medications after a period of time. Great question.
Dr. Sanchez, it's Nicole. You may have asked me to ask you if I wanted to bring a lot of this information back to my team. Where would I find it?
That's a great question, and good nudge. So first of all, if y'all are interested in these slides, there will be a PDF version available to anyone who wants it, or it'll probably be just sent out to everybody, so you can hang on to it or delete it, up to you. All the slides are referenced, and I think it's really good information that, can make it seem like someone like me knows what they're doing because I know what's on these slides, knows what they're saying. The other is that heart.org is our website. And in addition to all the things I talked about, heart.org can put you in a space where there is more information than you will be able to digest in one visit, but whether it's about women's health overall, things like the relationship between menopause and heart disease, you can find that there. A number of things are related to the work that the American Heart Association does. Heart.org, and then once you're there, it's fairly easy to navigate inside of heart.org. Is that right, Nicole?
Yes, absolutely.
And then, of course, your Louisiana team is there to help guide you as well. So anything you need, they can help you find it. I will say to you, I mentioned very, very briefly something called Target BP. You can go to Target BP for BP's for blood pressure.org, and you will find resources, video resources, some of that video resources in Spanish that you can use for yourself, that you can use for patient education with regards to blood pressure control in all. So that's available. I'm trying to think of where else to direct you. Target BP. Oh, I know what it was. Validatebp.org. That is not our website. Validate BP. One thing that I said I didn't emphasize is using the right equipment is really important for blood pressure control. And the American Medical Association has taken on the task of doing secondary validation of blood pressure devices for their accuracy, their reliability, and we recommend at the American Heart Association that whether it's a home blood pressure monitor for your patient, a kiosk for your community, or the machines you use in your clinical care settings, they should be validated devices. That's an added level of quality assurance that all the other countries in the world have embraced. They have their own Validate device listing, validatebp.org.
Does anyone else have any other questions? No. All right. Thank you so much for your time today, Dr. Sanchez. We appreciate
course.
you.
Happy to do it. Again, I just want to thank all of y'all for having an interest in this topic, but more importantly, what you do every single day to make a difference in people's lives. It helps us at AHA achieve the vision of advancing health and hope for everyone everywhere. And I can't stress enough, everyone everywhere, and also to be a relentless force for a world of longer, healthier lives. Y'all help make that happen. Thank you very much. Thank you for having me. And thank you, AHA staff, Nicole, Monica, Karen, and others for making it possible for me to be with y'all today.
I think the next couple slides of our presentation are about to pop back up. Yay. So before we leave today, there's just a couple little end cap notes, right? I'd like to share 2 upcoming opportunities for y'all to come hang out with the AHA team. Join us on April 25th at Aurora Plaza for the Capital Area Heart Walk. Our community chair this year is the Lake's very own Chuck Spicer. We're super excited to have him. Thank you for all the work that he's putting in for us. And our women's initiative, the 2026 Go Red for Women Experience in Luncheon at Le Berge, is going to be on Friday, February 6, 26 to 6/26. It's also National Wear Red Day. So even if you can't make the luncheon, mark your calendar, put your red on. It's going to be an experience, y'all, where we'll celebrate local change makers and continue our mission to improve women's cardiovascular health. And with that, please go ahead and scan the QR code for the post-program evaluation survey. We appreciate everyone taking the opportunity to fill that out. And it's also printed at your seat if you are here in person. But we will leave this up as we are headed out and everyone is logging off to give everybody an opportunity to grab the evaluation QR code. And I hope that you all have a very heart healthy day. Thank you.
He once told me the world is gonna roll me. I ain't the sharpest tool in the shed. She was looking kind of